We are live, sir. Hello, everyone. I am Adafshin from IDCP, and I warmly welcome to all our listeners for another insightful episode of the IDCP podcast. So, today we are discussing an exciting topic that reflects the rapid revolution of cardiovascular medicine. So, the topic for today is research to practice: the future of cardiac care. So, the cardiology is one of the fastest evolving field in the medicine every year. So, every year, groundbreaking research, clinical trials, innovative technologies, and updated guidelines reshape the way we diagnose, treat, and prevent cardiovascular disease. So, the real challenge, however, lies in the translating these research findings into the everyday clinical practice so that patients can benefit from the latest evidence based care. So, from artificial intelligence and the precision medicine to novel drugs and minimally invasive interventions, the future of cardiac care is becoming increasingly personalized and technology driven. So, to help us to understand how research is shaping tomorrow's cardiology practice. So, we are privileged to have with us today a distinguished cardiologist and academic leader. Introducing our guest, Dr. Professor P C Manoria. Sir, let me share some of his achievements with you all. So, sir is the director in Manoria Heart and Critical Care in Hospital in Bhopal. Sir is the former professor and the head department of cardiology, Government Medical College in Bhopal. Sir is the honorary physician to His Excellency the Governor of Madhya Pradesh. So, Dr. P C Manoria is one of the India's most respected cardiologists with decades of experience in clinical cardiology, academic medicine, and the cardiovascular research. So, his contribution to patient care and medical education have significantly advances cardiac health care in the country. So, sir, welcome to this IDCP, sir. We are delighted to have you with us today, sir. So, kindly you can proceed with the next, sir. Thank you so much, sir. It was great to having you. Yes, sir. You can share your PPT, sir. Sir, we are not able to see your PPT, sir.
Are you able to see?
Yes, sir.
Hello?
Yes, sir.
Are you able to see the?
Yes, sir. We are able to hear and see your PPT, sir. You can proceed with your PPT, sir. Thank you so
Okay.
much, sir.
So, good evening, everybody. For the next 20 to 25 minutes, I'll be talking on from research to practice the future of cardiovascular care. Medicine is essentially a resolution of uncertainty, and this has time and again been proved on several occasions. And it applies to cardiology. The research continues unabated 24 into 7 into 365, and the world of cardiology is changing very fast. Genomics and molecular medicine has stepped down from the lab to patient care, and it is poised to change the face of cardiac care. And we are amidst the dawn of a new era in lipid management with gene therapy, and three gene technology are going to revolutionize cardiac care in future. The first is antisense technology, which is a single stranded DNA, and gene editing CRISPR technology, which is a one-time treatment for gene editing for the rest of life. Premature coronary artery disease in India, all of us know, died and those who are not celebrities. ACVD, no doubt, is a multifactorial disease. All risk factors have to be targeted. But one of the major culprits for acute myocardial infarction is LDL cholesterol. Now, if you want to get the benefit of LDL cholesterol, you have to consider it as a lifelong marathon, which means you have to lower your LDL cholesterol from early life to the rest of the life, not for 5 years, 10 years, or for a decade. And if you lower your LDL cholesterol from early life to less than 70, the level at which there's a rest of progression of atherosclerosis, you are unlikely to develop coronary artery disease. Unfortunately, if you have developed an acute coronary event, then your LDL level should be less than 50, the level at which there's regression of atherosclerosis. There's no doubt we have a panoply of drugs, as you can see on the screen, but the biggest problem with all lipid lowering drugs is compliance, compliance, and compliance. It's very difficult for any patient to take these drugs for several decades. But now, gene therapy has come to our rescue to resolve the issue of compliance. Have you ever imagined a single injection will lower your LDL cholesterol for the rest of life? And this is true. Now, this is possible by gene editing with CRISPR-Cas9 technology. It has a two component, a guiding RNA which locates the specific genomic first, and the Cas9 nuclease which produces a double stranded protein. The guiding RNA has located the protein, and the Cas9 nuclease produces double stranded break in this gene. Aging heals case of and the LDL level drops down for the rest of the life. And this is one-time treatment. And this is the data published in May 2026 in NEGM. You can see VERVI 102, a single infusion for 4 hours. If you use it at 88%, the normal value is 35 to 225. And the LDL level drops down by 62%. So CRISPR-Cas9 technology has emerged as a very exciting option for lipid management. The technology has already been approved for sickle cell anemia, and hopefully it will be approved for lipid management also. What about LP little a? All of us know LP little a is a slow death warrant, but till date there's no approved treatment for LDA. But gene therapy is going to come. Why we are so much interested in LP little a? Because LPA-induced cardiovascular disease is a deadly disease and is because it's prothrombotic because of homology to plasminogen, and is pro-inflammatory and pro-calcific because of oxidized phospholipid present on LDL and ApoB. You can see lowering LP little cholesterol, small interfering RNA. This is pelacarsen, which is an horizon trial, which is likely to be released this year. A single injection of 80 milligram once a month lowers LPA by 80%. And this is the horizon trial, which is likely to be released this year. This is a secondary prevention trial. Then we have 3 small interfering RNAs, as you can see, olpasiran, which is being evaluated in a phase 3 ocean trial, evaluated in the acclaimed in a phase 3. Like this, we also have an oral molecule found to reduce LP by 65%. The beauty of small interfering RNA is they can decrease LP little a by more than 95 or even 98%. So LPA-driven cardiovascular disease is a slow death warrant, and hopefully if these trials come out to be positive, LP-induced cardiovascular disease will become a salvageable disease in future, and this will kick off a new dawn of LPA therapeutics. What about gene therapy for genetic hypertriglyceridemia? Now, when the triglycerides are elevated 300 and 400, it can be easily treated by the conventional treatment. But whenever we get genetic severe hypertriglyceridemia case like this, you can see triglyceride is 6,000 milligrams. And these patients usually suffer from recurrent pancreatitis, and the conventional therapy many times fails. So for this, we have again gene therapy, antisense to ApoC3, and this olezarsen, which is an antisense to ApoC3, is already approved by US FDA in 2025, is available commercially in USA after the BALANCE trial, which showed that 80 milligrams subcutaneously once a month lowers triglyceride by 43.5%, is not yet available in India because of increased bleeding due to low platelet count. And this shows that pancreatitis is markedly reduced by these agents. Now, this is another agent. You can see Prozarsen, which is a small interfering RNA, and you can see it lowers triglyceride, which means if your triglyceride level is 5,000, it will be slashed down to 1,000, and has been tested in pancreatitis in the PALISADE trial. Is already approved by US FDA. Then NGPTL is being targeted with two focuses. One for homozygous effect and another for mixed dyslipidemia. Now, NPTL has been targeted by several modalities of treatment, and these are the several trials which are targeting NPTL3. Now, this is the PRONG-ENG3 trial for mixed dyslipidemia, and you can see substantial reduction in VLDL cholesterol, LDL cholesterol, and non-HDL cholesterol. Now, sometimes we get patients, and you can see the LDL cholesterol is more than 500, 528, total cholesterol 60. Now, these patients are usually of homozygous effects. And you can see the usual manifestations, all these xanthomas, and they die prematurely because of myocardial infarction. And you can see all these manifestations which are there. Evanicumab, which is a monoclonal antibody against NPTL3, is approved by USFDA for treatment of homozygous FH. The problem with homozygous FH is they are hardly an LDL receptor, therefore statins, evolocumab, inclisiran, they don't act because they require LDL receptor. The beauty of this agent is its action is independent of LDL receptor, so it is a boon for patient of homozygous FH. NPTL also, interestingly, has been targeted by CRISPR-Cas9 technology, we showed you in the beginning, and this data was presented in AHA 2025, and you can see a single infusion of CRISPR, this technology decreases NPTL by 48.9% and triglyceride by 55%. So we are amidst the dawn of a new era in lipid management by gene therapy, and time has come to rewrite the script of lipid management. Hypertension, again, the biggest problem in hypertension is compliance, compliance, and compliance. It's very difficult for any individual to take the drug for decades together, maybe lifelong. But here again, gene therapy has come to our rescue, and drug therapy for hypertension can now take a vacation. And this is zilebesiran, which is a small interfering RNA. A single dose of 300 milligram lowers blood pressure for the next 6 months. And this targets angiotensinogen. It decreases the production of angiotensinogen in the liver, and therefore angiotensin 2 level decreases and the blood pressure is controlled. This has been tried in phase 1 and phase 2 trials, and this is data from the cardio 3 trial. You can see a single injection decreases blood more than the placebo. Substantial reduction on an ambulatory blood pressure monitoring. And if you happen to be in a diabetes, you can see the blood pressure decreases blood pressure is reduced by 21.3, 9.2 more than the placebo. The phase 3 CV outcome trial is ongoing, and the primary endpoint is cardiovascular death, non-fatal MI, non-fatal stroke, and HF event, and we're keenly awaiting the results of this phase 3 trial. Now, this angiotensinogen is also being targeted by CRISPR-Cas9 technology so that it will become a single-time treatment for the rest of the life. Acute coronary syndromes and chronic coronary syndrome has also undergone revolutionary changes. We have a panoply of imaging modalities which can tell us the pathophysiology of coronary artery disease and are utilized during percutaneous substitution so we can optimize the results of these patients. Structural heart disease, which was once upon the domain of the cardiosurgeon, say prior to 1984, but now you can see it has become a domain of the interventional cardiologist for majority of cases, whether it is aortic stenosis. Now, aortic regurgitation was also targeted by TAVI, by the Align trial, whether it is pulmonary stenosis or whether it is mitral regurgitation. We have can also be given pulmonary artery denervation for pulmonary artery hypertension. Regenerative and stem cell therapies in cardiovascular care. All of us know heart failure once sets in, runs a malignant progression with a very high morbidity and mortality. The 5-year mortality may be to the tune of 50%. Drug therapy, device therapy, no doubt blunts this malignant progression, improves quality of life, and improves survival, but does not arrest this process because the human myocytes are not endowed with an endogenous capacity for repair. Once dead, are dead forever. And therefore, cell therapy has emerged as a very exciting option, but after several decades of research, we do not know it's the end of the beginning or beginning of the end, but I'm sure some researcher will one day succeed in cell therapy. Digital twin technology has come in vogue for diabetes care. In this, various parameters of a diabetic patient are fed into the computer, and a digital twin is created day to day, and this helps in management of these patients. And you can see this is the 1-year outcome of a digital twin intervention for type 2 diabetes. You can see significant improvement in HbA1c level of digital twin intervention. You can see this green has dramatically increased, less than 6.5. Improvement in CGM, this is the time in range. You can see significant improvement in time in range. Significant reduction in the anti-diabetic medication and significant reduction in the anti-diabetic patients after 1 year. So digital twin is a big step in diabetes management and could play a vital role in the future of diabetes care. Obesity is closely linked to cardiovascular disease, and therefore, as a cardiologist, we are always interested in obesity care also. And currently, time has changed to project the new phase of obesity. Obesity is not only a disease, it is a new diabetes, and obesity can be minimized. All cardiometabolic disorders will become a rarity. The second big message which is coming from the new phase of obesity is treat obesity with new anti-obesity medications like semaglutide and tirzepatide and get cardiometabolic renal protection in future. And this protection, cardiorenal metabolic protection, is based on large number of outcome trials, as you can see on the screen. During the last couple of years, there has been a drug revolution in obesity. We have single agonists like semaglutide, which in the STEP trial has shown reduction in it by 50 to 17%. And after the SELECT trial, which is carried out in non-diabetic obese patients, it has been approved to improve cardiovascular outcome in non-diabetic obese also. You can see if your BMI is more than 30 or if it is less than, you can. We have a dual agonist like tirzepatide, which was tested in the SURPASS trial, and this shows reduction in it by 9.5 to 13 kg. And in the Surmount 1, it shows reduction of 22.5% reduction in weight. And cagrilintide is another drug combo which has also shown significant reduction in weight. And we now have triple agonist retatrutide, which in the phase 2 trial showed 24.2% reduction in weight. And this is the recently released trial. You can see the Trump trial. The reduction in weight with 20%, which is just like a bariatric surgery. So you can imagine the significant reduction in weight with this triple agonist. We also now have de-escalation protocols because it's very difficult for any patient to take these anti-obesity medications for several years. So you can have continue the injectable agents with lower dose, or you can switch to an oral agent, and if they to maintain your lost weight. Several other agents are in the pipeline, and this is another newer subset of agents, the non-peptide agents. Of these agents are they are not associated with the hassles of oral semaglutide. All of us know if you take oral semaglutide, you have to take it on an empty stomach, not more than 100 ml of water, nothing to be taken by mouth for next 30 minutes. But these agents don't have this advantage, and the orforglipron has already been approved for treatment of the USFA after the Attain trial, which shows a reduction of 11.2 milligrams in a dose of 36 milligrams. Then we have quadruple agonists which are under evolution: GIP, GLP, amylin, and calcitonin, and another quadruple GLP, GIP, glucagon, and Y2R. Once monthly injections are also available. You can see this is a cefraglutide, which is once a month injection, unlike semaglutide or tirzepatide, which is once weekly. This is another newer agent. This is every week. And this is another injectable agent which has also shown substantial reduction in weight. Usually, when we talk of any drug for clinical use, the dicta is one size does not fit all. Whether you talk of acute myocardial infarction, hypertension, heart failure, or whatever it is. But these newer agents like semaglutide, it is one size fits all. You can see if you use semaglutide, you not only decrease weight, you improve diabetes, ACVD is benefit, HF, CKD, dyslipidemia. So these agents have kicked off a new era of cardiometabolic revolution which never existed. Tirzepatide is also showing similar data, but some of the trials is in progress, and I'm sure this will also fulfill the same results. Insulin has been the savior for type 1 diabetes, but now will new anti-obesity medications will be the savior for cardiometabolic diseases? Possibly yes. Now, whenever we are using these new anti-obesity medications, there are several side effects. You must be aware of all these side effects. One of the most important side effects is sarcopenia, because this should be prevented, or if it occurs, should be diagnosed at the earliest. You should advise high protein diet and resistance training. We don't want our obese patient to walk like this. Don't forget, muscle is an organ of longevity after heart in an elderly individual and those who are new anti-obesity medications. And therefore, the big question is, in future, will it be possible to have fat loss without muscle loss? Trial of bimagrumab, which is a muscle building agent, along with semaglutide, is in progress in the BELIEVE trial, and we are keenly awaiting the results of BELIEVE trial, whether this goal we will be successful. 10 things you must not forget while using injectable semaglutide. Focus on fewer meals and no meals. Don't ignore protein. Don't go to zero carb. Don't forget to hydrate. Don't rely on medication alone. Don't eat heavy greasy meals after your dose. Don't stop straining. Don't obsess over the score. Don't quit too early, and don't try to take help of all the other dietitians, physiotherapists, and so on. Wearable digital devices and wearable health technologies have also made tremendous progress, and you can have various parameters right on your screen in your watch. So all these parameters you can have on your screen and you can see any time of the day. Artificial intelligence and is also coming in a big way and is the future of medicine. ECGs, interpretation, echo, MRIs, angiograph interpretation can be done with artificial intelligence in a better way. And artificial intelligence have large number of applications and time does not permit. So progress in cardiology never stops. It will continue, and whenever we deliver lecture in future, there will be new data, new technologies, and newer results. Thank you very much for the kind attention.
Okay. Thank you so much, sir, for this wonderful presentation, sir. So, with all your permission, sir, I'm going to take a question one by one. So, the first question we received, sir, which recent landmark clinical trials have had the greatest impact on current cardiology practice?
See, the greatest impact is going to be with gene editing therapy because all preventable diseases, the problem is you have to take therapy virtually for the rest of the life, whether it's hypertension, whether it's coronary artery disease, whether it's heart failure. Now, if this gene editing with CRISPR technology is successful, it's already being tried in human patients, already approved for sickle cell anemia with a single injection infusion for 4 hours or so. You will be able to edit a particular gene and you'll get the benefit for the rest of the life. So we are very hopeful that in times to come, if this becomes successful, this will be the most uh, impactful trial for our clinical management.
Okay, thank you so much, sir. So the next question is, sir, how are advances in imaging, wearable technology, and artificial intelligence changing the diagnosis and the management of heart disease?
See, artificial intelligence, wearable technology, all these things are changing the cardiology practice. Sometimes when there's confusion, artificial intelligence does come to our rescue, particularly when there's a lot of differential diagnosis, helps in arriving at a diagnosis. You can have various vital parameters right on your watch, round the clock. You can see how many steps you have walked. For example, usually a young individual is required to walk 10,000 steps. You can see your blood pressure, what is happening to your glucose, and many other parameters are your own wristwatch these days.
Okay, thank you so much, sir. So the next question we received, sir. Uh, Sir, precision medicine is becoming an important concept in healthcare, sir. What role do you see it playing in the future of cardiology?
Precision medicine is going to play a big role, and in future we will be again with genomics and all these technology. We will be able to impart a precision therapy for that particular agent because we know every patient does not respond to the same drug. Every patient does not have the side effects. So before administering any drug, we will be able to how is he going to respond? Is he going to get the side effects? So precision medicine is coming with a big way, and polygenic risk scores and all these genome monitoring this will be helpful.
Okay, thank you so much, sir. So the next question is, sir, what role will preventive cardiology play in reducing the future burden of heart disease and particularly in countries like India?
See, today we have excellent drugs for heart failure, for hypertension, for coronary artery disease, and so on. No doubt they decrease morbidity and mortality, improve the quality of life, but they do not decrease the number of patients. So the number of all these preventable diseases is going to increase and increase. So they can only be decreased by primordial prevention. So if unless we don't adopt primordial prevention, the number is going to increase. And the best candidate for primordial prevention is the nursery kids. Trials have shown that when we teach the nursery kids lifestyle modification, they continue to follow up in the later life, and all these risk factors usually are minimized or they do not develop. So our motto will be stop hypertension, stop heart attack, stop heart failure. These can only be done if you follow primordial prevention. Primordial prevention is a difficult thing to adopt. It will take decades or maybe centuries before the fruits of this are seen on the population. But it is the only way, otherwise, the same trend continues. The number of all these preventable cardiological diseases will continue to increase.
Okay. Thank you so much, sir. So, as I can see, sir, there is no more question is left, sir. So, today's discussion has highlighted that the future of cardiology lies in the successfully translating cutting edge, different research into practical. So, sir, with all this, sir, I'm going to conclude this session, sir.
Thank you.
Yes, sir. So, on behalf of IGCP, sir, I sincerely thank you to you, sir, and to all our listeners for joining us today. So, thank you so much, sir, for listening. Stay healthy and stay informed. We'll see you in the future next session of the IGCP series, sir. So, yeah, with all this, sir, I'm going to end this session, sir. Thank you so much, sir. It was great to having you.
Thank you.